Okay, good morning, Singapore. Welcome to the Asia Pacific Intensive Care Symposium, Symposium number 10, RRS, Rapid Response Systems, also related to Rapid Response Teams, or RRT. For those in the audience who work in the local public sector, RRT has a different meaning relating to COVID swabs, but this is RRS, Rapid Response Systems. Today, we are fortunate to have 3 speakers from around the world to tell us more about the role of rapid response systems in various aspects of what we work in the hospitals. And I think we're in for a treat with hopefully a really intense discussion on some of the controversial issues surrounding RRS. So on your screen are the 4 sort of talks to kick us off the discussion, and we'll go right into it with our first speaker, and I'll introduce him. But before I do that, feel free to put your questions into the chat, and we will get to your questions at the end of the 4 short talks that we will give. And we will have a fruitful discussion after that. Okay, so may I first start with Professor Daryl Jones. So I'll introduce him first. Professor Daryl Jones graduated from the University of Melbourne in 1996 and is an intensive care specialist at the Augustine Health in Victoria, Australia. Daryl is also an associate professor at Monash University and adjunct professor at the University of Melbourne, and an advisor to the Australian Commission on Safety and Quality in Healthcare. He's completed a Doctor of Medicine in aspects of the Rapid Response Team, and also completed a PhD on the RRT that will assess the characteristics and outcomes of patients who are reviewed by the RRT, and details of resource utilization of the medical emergency team in ICU-equipped hospitals throughout Australia. Daryl is also the Medical Director of Critical Care Outreach at the Augustine Hospital, and is the President of the International Society of Rapid Response Systems, and has previously convened 6 annual N6 conferences on deteriorating patients. So Daryl, welcome, and he'll be talking to us about rapid response systems to save. Over to you, Daryl.
Thank you very much, Augustine. I'd just like to thank the organisers for this invitation. I feel very honoured to be invited So as Dr. T alluded to, I'll be talking about rapid response systems to save and real requirements for successful rapid response system. I have no financial conflicts of interest to declare, only academic. I'm the medical director of the outreach at Austin. I guess that could be a financial conflict of interest, given that that's one of my paid jobs. All of my opinions are my own. I'm actually now the past president as of June this year, and they're my other academic conflicts of interest. I have a number of higher degree students doing research in this area. I'm going to give a very broad overview of what I think is essential for using a rapid response system to save patients' lives. I'm going to talk about the initial elements of the rapid response system as they were described in 2006, and then from Australia, requirements for rapid response systems initially published in April 2010, but more recently in 2017. And particular, I'm going to talk about the 8 essential elements of recognising and responding to clinical deterioration. I'm going to talk about Austin Health, a real-life example, and I'm going to provide evidence of effectiveness from Australia. So this is the initial elements of the rapid response system. This was published in 2006 in Critical Care Medicine, and Dr. Michael DeVita was the first author, and it outlined the 4 arms or the limbs of the rapid response system. So they were the afferent limb, which is the calling criteria or the triggers, and the staff that identify that, and then the activation, usually via a switchboard, sometimes via automated systems using some sort of electronic paging or push system. And then there's the responding limb or the efferent limb, and that is the medical emergency team or the rapid response team or the critical care outreach team. And they are the responders that actually come and see the patient that has had a change in their clinical status. Sometimes they can link to specialised teams like cardiac arrest, trauma, stroke or sepsis teams, more recently pulmonary embolism teams. And so that's the bare essentials of the rapid response system. However, to oversee and to coordinate this, you need an administrative limb, but you also need a data collection and analysis limb that ensures the constant plan, do, study, act, PDSA cycle for quality improvement. So this was published in 2006. This is now 15 years ago. The one thing way back in 2006 was emphasised in this approach was this is a whole of hospital approach. It doesn't just rely on individual doctors or even a team of clinicians. It needs administrators and clinicians to interact with each other in order to achieve a comprehensive whole of hospital response to deteriorating patients. One of the things that's been overlooked is the detection arm or the afferent arm actually provides objective criteria to help staff on the ward identify patients that may be deteriorating. The response limb, the rapid response team or the MET actually suggests that there is an expected response when clinical deterioration is detected. And as I alluded to, there are quality improvement and administrative limbs. So that was the introduction to the rapid response system, first defined in 2006, 15 years ago. Step forward to 2010 and more recently 2017. In Australia, we have a national consensus statement on recognising and responding to clinical deterioration, and it outlines what are called 8 essential elements. There are 4 clinical processes and 4 organisational prerequisites. I can strongly recommend this book. It's only about 25 pages long, and it's available online. If you just Googled the consensus statement from the Australian Commission on Safety and Quality in Healthcare, you can easily find it. And I'm going to highlight a few of the important essential elements. I won't have time to go through all of these. So the first one is the measurement and documentation of vital signs and other observations. And I would ask all of you in the audience to check in your hospital to see whether your hospital actually even has a policy on this. This element of the consensus statement outlines the measurements of vital signs in terms of the timing of the assessment, that it needs to be done in conjunction with other observations and other assessments, and it actually clearly articulates the minimum requirement of a set of vital signs. It does not recommend just doing 1 or 2 of these vital signs. It recommends the vital signs that are listed. So respiratory rate, oxygen saturation, heart rate, blood pressure, temperature, and level of consciousness. And it suggests that recommends that you need to have a structured tool, and this tool should actually guide the escalation process. So all hospitals in Australia now must have some sort of a graphical representation chart, and this is the old one before we went electronic at the Austin Hospital. You can see that respiratory rate is on the top, and you can also see some numbers down the side for the various measurement of that vital sign. You can see some color coding. So orange dictates that you must call the parent unit and they must respond in 30 minutes. And if you reach the purple zone, then you must activate the hospital medical emergency team system. So not only does this provide a graphic representation all on a single page of the vital signs so you can see the trends, if the patient is outside of the white zone, then you must activate some sort of a response. So it's not just a vital sign chart, it also provides decision support for the treating clinician, typically a nurse, to achieve a response for the review of that patient. The next step is the escalation of care. We're still in the afferent limb. This outlines that a hospital must have a policy outlining who to call when these vital signs are abnormal. And importantly, it authorises and supports the clinicians at the bedside to escalate care until they are satisfied that an effective response has been made. So this is the direct quote from the consensus statement. This means that the clinician can never be criticised for calling up to the head of the unit. So that's typically a doctor or the nurse unit manager in the hospital. It emphasises that the approach for each individual patient needs to be tailored for the level of deterioration, for the nature of the hospital, and it also, you may need to change the frequency of vital signs depending on the development of deterioration. This response should be graded, and I've alluded to the 2-tiered response in most Australian hospitals, where you call the clinicians, usual treating team for mild deterioration, or the medical emergency team for more severe deterioration. And every hospital in Australia must have a patient, family and carer escalation pathway. So if the patient is concerned, or their carer or their family is concerned, they have the authority and a mechanism to activate a response that bypasses the bedside clinicians. And I can talk about that in question time if people would like to. One of the other essential elements is the leadership and governance, and everybody has an organisational structure or flow diagram. This is the one for the Austin Hospital deteriorating systems. We have the board of quality safety up the top, and then there's a committee underlying that, and then there's a deteriorating patient committee, which has multiple committees underneath it. This deteriorating patient committee has about 40 members. We also have a MET panel to oversee the day-to-day running of the medical emergency team. And importantly, the deteriorating patient committee has replaced the previous resuscitation subcommittee. So we no longer focus on just patients having cardiac arrests. We no longer focus just on patients having a medical emergency team. There is an overarching deteriorating patient committee that oversees perioperative medicine, end-of-life care, deterioration on the subacute or the rehabilitation campus, the patient and carer escalation, mental health deterioration as well. So it is extremely comprehensive. And I've actually co-authored a chapter with our lead, Melody Heelan, who's our executive or administrative lead for the deteriorating patient committee. The next essential element is audit, evaluation and feedback. And I'll just skip through 2 of the essential things that we have in our hospital. The consensus statement emphasises that if you you must collect data in your hospital, and it needs to be fed back to clinicians at the bedside, and I'll show you how we achieve that at our hospital. Many units in our hospital review and discuss their MET calls and code blue calls at their own morbidity and mortality meetings, and each week we have an automated push report that's generated automatically, and is sent to a lot of clinicians and administrators in our hospital. So this is the dashboard. This appears on our intranet, and it outlines the number of MET calls that have occurred each month. So this is up until April this year, the wards that they occur in, and I'm sure there are hotspots in your hospital. These 2 wards are where most of the major abdominal surgery occurs. The colorectal, upper biliary, all over liver transplants are on those wards, and you can see the particular units that are the unit most responsible or most frequently calling MET calls, and the trigger for that. This is actually live. I haven't got it live here, but if you clicked on general medicine, for example, all of the information for general medicine would come up. And when you click on the individual month, you can drill down to individual de-identified patient data. So this is available for all employees within the hospital to review the MET calls in your own unit. And every week there is a push report of similar data outlining the wards and the units and the trend for the 24 months of MET calls. This month had just started. So we have about 300 to 350 MET calls per month at the Austin Hospital at the moment. The next important element to ensure that you save patients with your rapid response system is that you must have some sort of an audit or research agenda. It's not sufficient just to audit things. You need to have an overarching approach or direction and some major research questions to guide and direct that research. In our hospital, we're trying to understand why patients develop clinical deterioration, and we're also trying to improve training, education, and oversight for junior doctors. And these are our research objectives for the next year. We've had 26 publications in the last 5 years, and I would strongly encourage this if you're the medical or nursing lead for the outreach in your hospital. This engages other clinicians along the quality improvement journey. These are sent to peer-reviewed journals, so you get feedback from world experts, and it also allows you to share your knowledge with others. The next important aspect of the essential elements is education and training, and we have fortunate in our intensive care to have a couple of consultants who've undertaken the Harvard simulation program, and they lead our education and training for simulation training in the medical emergency team and for deteriorating patients. The intensive care staff also provide extensive education and tuition for the junior doctors in order to teach them how to better recognise and respond to clinical deterioration. I now want to go through what is the evidence for this. So I'm going to present 2 studies and just walk you through them slowly. So this is a study between 2007 and 2014 in Victoria, which is the state that I live in. This study looked at 4.7 million hospital admissions from nearly 220 hospitals, and it showed that when we implemented this standard in our state, all of those essential elements, there were reductions in in-hospital cardiac arrest for patients on the ward. There was a reduction in heart failure and fluid overload in patients on the ward after their admitted to the hospital, and also a reduction in arrhythmias. And this is the same information shown graphically. So this is before we introduced the national standard in 2010. And as I said, there was a dramatic reduction in cardiac arrests, in heart failure, and a plateauing of arrhythmias, which were rising before. And if you do the statistical technique interrupted time series analysis, or ITSA, you can show that this was a statistically significant reduction in these important clinical outcomes. So that's for the whole state of Victoria, and this is every single hospital in the state of Victoria. There's 218 hospitals. If you just look at intensive care equipped hospitals, not every hospital in Australia or Victoria has an intensive care. There were 110 hospitals over a similar time period contributing data to our national database. And when we looked at all of the hospitals admitted when we had admissions just from the ward, looking at patients who had a cardiac arrest, we similarly found quite dramatic reductions in patients admitted to the intensive care following a cardiac arrest. And amongst those that were admitted that survived and got to the ICU, there were reductions in the proportion that were mechanically ventilated. The intensive care mortality reduced by an absolute percentage of 7%, and there was about a 7% reduction in hospital mortality. This has been published in Critical Care Medicine in 2018. So this is quite a dramatic improvement, and as you can see, it's mostly cardiovascular type complications, particularly cardiac arrests, heart failure, and also dysrhythmias. The last or second to last thing I want to talk about is the importance, I think, of providing senior oversight. Patients who have MET calls are very, very sick, and they actually have an in-hospital mortality that's higher than patients who go to the ICU. Certainly in Australia, that's the case. Recently at the Austin, we've introduced a new role, a consultant or a specialist that oversees everything outside the intensive care unit, and we've called them the critical care outreach physician. Colloquially or casually, we call them the COP, because they're trying to find all the bad stuff that occurs outside the intensive care. And this was a pilot study where we looked at the first 100 visits. We're aiming to try and do regular preemptive reviews and coordinating intensive care admissions, but also review MET calls, particularly when a patient has had more than one MET call, or they have sepsis. And sometimes we have two simultaneous calls going off at the same time. And that allows us, this role allows us to divide and conquer. You can see that the consultant during this 100-day time, 100-day period, spent a lot of time doing high-level things like speaking directly to consultants, coordinating ICU admissions, so that's approximately 2 a day, every day, expediting care, reviewing patients, actually attending MET calls, and having goals of care discussions, so end-of-life care discussions with either patients or their family, or guiding discussions in about a third of the reviews. This was a busy job during the pilot, and it's becoming even busier with time. This median number of 14 encounters a day is up to about 20. So there's about 2 encounters every hour in this 10-hour shift. And this will appear in critical care and resuscitation in September, and we'll have data early next year with a year before and after to see whether this has improved important patient-centered outcomes. So in summary, using the rapid response system to save patients or reducing failure to rescue needs a number of important aspects or components. And the most important one I need to emphasize is that it needs to be a whole of hospital approach. And you need some sort of proactive governance system. And I would contend you need to think about having a deteriorating patient committee. If you only have a cardiac arrest committee or a resuscitation committee, you will only focus on resuscitation. You need a broader, more broad-based committee that look at deteriorating patients in a much more complex and broad-based sense. You need to have dedicated staff, both for administrative elements but also clinical elements. I do not recommend you have a team that is also your ICU team that has to leave the intensive care to go out and see patients on the ward. That simply doesn't work. They don't end up doing a good job, either inside or outside of the ICU. You should have a structured audit and research program and some sort of a process for continual quality improvement. And I'll leave it at that. So that's my Twitter handle. That is the link to the Rapid Response System International Society. And if you're interested in rapid response systems, the Society will be having a webinar on the 23rd of July. And there's also the Patient Safety Congress in September. Thank you once again for the invitation to present. And I'll be delighted to answer chat in the chat and to answer questions at the end. Thank you very much.
Thank you, Daryl. That was very interesting. I mean, in medical literature, some standards don't make a difference, but it's great to see how the standards have made such a significant difference in Australia. So we move on to our next speaker. He's Dr. Alex Psirides. Alex is the co-director of the Tertiary ICU in Wellington and medical director of the Regional Aeromedical Retrieval Service. He's trained in London, Australia, and New Zealand, and has been involved in the design and implementation of rapid response systems to detect and respond to inpatient deterioration in several countries. His work and research in this area led to an appointment as the National Clinical Lead for the New Zealand Health Quality and Safety Commission's 5-year Deteriorating Patient Program. Through this work, New Zealand has implemented a national evidence-based early warning score, a standardized vital signs chart, a patient and family escalation system, and a national shared goals of care approach to ensuring all treatment provided to inpatients is both wanted and warranted. He's interested in how hospitals often fail to recognize dying patients and thinks we could and should do better. He would rather meet international colleagues in person than through Zoom, but this is inevitable. I won't go through the rest of his private bio, so I hand over to Alex. Over to you.
Thanks, Augustine. Thank you again, as with Daryl, for the invite, for having me once again. I would much rather be in Singapore in person than in the middle of a Wellington winter, but such is life. I've been asked to talk about rapid response systems to comfort, which is a bit of an acronym cram, but we got away with restoring rest for the soul. This is almost a part 2 of a talk I actually gave in person in Sydney a couple of years ago, talking about why doctors don't recognize dying. So I'm going to start off with a sort of motherhood statement and then a bit of a brief literature review that I've just noticed includes papers both from the speaker before me and the speaker after me, which is not coincidental but inevitable because they are such awesome experts in this field. So I want to start with, I guess, how we've lost some stuff along the way and have some questions and thoughts about why rapid response systems are now being used for one of the purposes for which I think when we started, they were never intended. I've got 15 minutes, and what I'm going to cover is how, in our rush to complexity and cure, we may have got slightly lost along the way with regard to focusing on what may or may not be the important things that patients want. So let's start with some patients. Let's start by asking them what they actually want from all of this. This is a study done by The Economist in 2017, so not an august medical journal, but probably reflects the increasing interest, at least in public-facing literature, about what people want. This was a study where they asked people where they actually wanted to die, and you can see there was a variety of countries that were involved in this. Perhaps not surprisingly, the vast majority in every country that represents a sort of mixture of different countries, the US, Europe, Asia Pacific, and South America, the majority of people think that they want to die at home, and they're sort of sitting around somewhere around the sort of 60 to 70% mark for most of these people. When you then ask them where they think they're most likely to die, you can see the number drops significantly. So there's already a disconnect between where people want to die, but where they recognize the system is probably going to force them to die. And if you look at Japan, you can see that most people think, unfortunately, they're going to end up dying in a hospital, even though over 55% of them said they actually wanted to die at home. If you then look at where people actually die, there's a significant variability. This is from a paper from 2013, and I have referred to my virtual hosting colleagues here. Singapore, you can see, sits somewhere in the middle. And for reasons that aren't immediately apparent, even though I've lived here for 20 years, New Zealand is the place where it seems that least people are going to die in hospital, and there's an even split between residential aged care and their private home. Japan, as the residents correctly predicted, indeed are those most likely to die in hospital. But there is a large variability, as you can see, between what people want and what people actually get. So I was going to talk briefly through how the literature sees this. When we started with medical emergency teams, as Daryl had alluded to, they sort of came out of Sydney in the late 1990s from Prof. Ken Hillman's work. And we have come a long way since then, as Daryl's just presented his tour de force of what probably the world's most functional medical emergency team system looks like. He described end-of-life care in a pilot study back in 2007, which was where we were starting to realize, I think, that medical emergency teams were also now going to be inevitably involved in decision-making around how people die, and in fact, whether treatment that's being provided is futile or not. And this was the first paper to describe that patients who died who were designated not for resus at the time, a third of these patients were seen by the Met team before death. And as Daryl's described, in about 10% of these cases, the Met actually participated in the decision to designate the patient not for resus. So rather than now starting to be attending sick people, the Met is now being involved in decision-making around actually what is correct treatment and what isn't. This was a paper from our Met service that we published. We looked at a variety of things in 2011, mainly looking at limitation of treatment orders and where they sat with regard to medical intervention. So it was a retrospective study that's relatively easy to do, which was to look at patients who had Met calls and to look at any documented evidence of limitation of treatment. And what my colleague, Dr. Knott, found was essentially that after a Met review, it doubled the amount of patients receiving treatment limitation. So the green bar is patients who are for full treatment before the Met call, and in the immediate 24-hour period after the Met, the patients who are still documented as receiving full treatment has now halved. Now, obviously, some of these will come from the Met team themselves making limitations, but some of these will also come from the parent team coming on the next day to find the patient had a Met call that may or may not be refocusing where they think this should be going. Daryl's back with another paper. This is a much larger one, and this is now multi-center, where they decided to look at the epidemiology of Met treatment that's actually involved in end-of-life care. This is papers from Sweden, Canada, and from Australia, and teams looking at what actually the Met call did. And what they found was that predominantly the patients who had treatment limited by the Met, this was occurring elderly patients. They were generally more likely to be under a medical specialty than a surgical one, and perhaps not surprisingly, given the Met operates a 24/7 service, were more involved in doing this out of hours, given that the parent team are usually only on site for office hours, which is 8 to 9 hours a day for 5 of the 7 days of the week. This is another paper from Australia. This was looking at a systematic review, and they found that this number that Daryl had initially described with limitation of medical treatment being initiated by the Met in 10%, over the years has now gone up to probably around about 30% of Met calls. So we now see that the Met in 1 in 3 cases is actually involved in making decisions about treatment limitation, as well as in the majority of treatment that is going to be provided. This is from Canada. This is from Speaker Who's to Follow. You can see that what they found in 2014, what they described, is that rapid response team-led end-of-life discussions actually reduced intensive care admissions and increased palliative care access. So the Met now is being used to do a couple of things. By leading end-of-life care discussions, there's obviously a reality where if patients decide they don't want ICU, they now have a mechanism by which they can tell another team. And also the Met may be able to refer patients to palliative care if the home team haven't been able to do so or haven't done so. This was a study from New Zealand that we wrote. This essentially was following up patients who had Met calls. This was a prospective study over 2 weeks in 11 New Zealand hospitals where we watched 313 patients who had Met. And we plotted the Kaplan-Meier to see what happens to these people up to day 30. What we found, as you can see down there on the x-axis, is that there's a relatively steep drop-off within the first few days in terms of people dying. But by the time we get out to a month, 1 in 5 of patients who received a Met call have actually died. So the Met is being used to identify or indeed modify the reasons why patients subsequently die, because treatment that would otherwise be futile is no longer being provided. And finally, skipping up to a paper that was just published last month by Professor Mitchell's group out of Canberra. There is a standard, as Daryl had alluded to, not just for rapid response systems, but also for providing end-of-life care in Australian hospitals. So it seemed timely, as it's been out for a few years, to review and see actually those patients who die in Australian hospitals, how well it's being used. The description of what they found is slightly depressing. They found advanced care plans are only prevalent in 12% of patients, and that of the Australian patients who die, death recognition mostly occurs within the last 48 hours of life. And because of this, 60% of patients are receiving investigations and interventions during this time with somewhat late symptom relief. So this at least would suggest that all is not well despite having a standard, and makes a very valid request for possibly a focus on more discussion around possibly, firstly, advanced care plans before patients present to hospital, but also improving why doctors may recognize death or how doctors may recognize death. So I just want to briefly recap some of the stuff I've talked about before, just to push on about how we got to where we are and why a lot of people are actually being met by the Met before they die. We have invented a system, of course, where if you become ill with an acute illness, there is a conveyor belt that carries you through the hospital if you continue to deteriorate through meeting the Met team and then ultimately in the intensive care unit. And once this process starts, it's actually quite hard to not get to ICU if the intensivist deems you worthy of receiving care, by which I mean they believe that you actually have a reversible component. And because of this, we deny patients a good death at many, many opportunities. It's almost as if in some places getting into ICU is too easy. And we've talked a lot about how conversations with patients are difficult and these may be avoided. And the default provision of everything means that you end up being seen by people who may be put into difficult situations where they're making decisions about you without knowing you that well. And what this leads to is what I've repeatedly called a bad death, which for the reasons I've just talked about is the default. The bad death is a death that the patient would not want for themselves. And as you said, the expectation that you die at home surrounded by your family and loved ones in a peaceful way is not going to be met if you present to a hospital with an acute deterioration or present with an illness that then subsequently acutely deteriorates. So by nature, what happens is you have a group of strangers around you who are more likely to be clinical staff. As Professor Mitchell's work has showed, it will occur during or soon after a procedure that was never going to change the outcome. You will be accompanied in your death by monitors, alarms, and needles being put into arteries and veins. And it's the very antithesis of what most people would want. There's a lack of dignity. Often during Met calls, your body is exposed for examination and cannulation. And there's this complete ignorance of what you may want from a cultural or spiritual perspective. But I think most importantly, one thing that recurrently shows up in the literature and from talking to patients and families is that patients on the majority may actually have been unaware they were dying because no one's actually told them this. So not only are you depriving them the chance to say goodbye to family and friends, the patients are carrying on with their life in the assumption that they're going to carry on at least to get out of hospital, when the reality is in many cases that's not going to happen. So here's a relatively simplistic thing about what happens to patients. When they're admitted to hospital, they're really going to go into one of two ways. The vast majority, of course, are going to recover and going to be discharged home. But there are a number of patients, depending on your hospital type and the number of patients you're admitting, obviously, where the Met team is going to be meeting these patients. And the whole point of the Met initially was, of course, to turn you around. That as you deteriorate, you hit this Met line where the Met team are triggered and they improve your care. They start something new. They find something that the home team hadn't found, or they just simply do more of the same and you get better and go home. But there's this intersection where the Met team may be meeting you, but of course you may cross trajectories, mainly because the Met team may actually be limiting your treatment. So what this leads to is this situation when the Met meets you, where it's actually very hard to differentiate between which of these two groups you're going to be in, because dying people and sick people genuinely look the same. And as I've said before, it's very likely the Met process, for the reasons Daryl's shown you on his chart, as you physiologically deteriorate, you'll go through the home team. If you continue to deteriorate, you'll end up under a Met. And working out acutely in a patient you don't know, you've never met before, pun intended, is someone who has an irreversible process that you can't actually influence, or actually a reversible process who would benefit from aggressive care is quite difficult. This is a diagram I use all the time because I still think it's the most relevant to why we're involved in this as intensive care specialists, and also to talk about why we're different to palliative care specialists. Palliative care, of course, death is their business, but not so much death, but also making sure that actually having the patient at the center of the decisions around them and making sure that any medication or treatment offered is only to actually improve the quality rather than the quantity of that patient's life. So what's this going to do with us? Well, we see a lot of death. By the nature of intensive care, for our unit at least, we admit 1,800 patients a year. We have a 10% mortality. That's 180 people who die in a year. So every other day, someone will die in the intensive care unit. But obviously, almost all those deaths are elective deaths. It's a withdrawal of a process because we realize that ongoing treatment is probably going to be futile. By the nature of the systems Daryl has described in a fully functional Met system, and again in New Zealand with the early warning score we've implemented, if you're dying, you will meet the Met team, because the system forces the nurse or the other doctor to call for you to come and see them as you pass through Met calling criteria. And this is the main difference between the Met and the palliative care team. The palliative care team have to be invited in like vampires, as I've said before. They cannot cross your threshold unless you ring them. And the insight that requires you to do that may be variable depending on which team you work for. For the intensivists, you have no such qualms. You have a physiological system that means you must be activated and you will meet a lot of dying people as a result. And this is really where we're different. We're also physically available 24/7 in some form, whereas palliative care, generally speaking, aren't in most hospitals. So how does this work? Why are we different? Why is it, for example, that the intensivists are here and we are able to provide rest for the soul, but to choose another specialty, surgeons who are much vilified but have a different mindset? And I can only speak from my own mindset, not from theirs, because I could never, ever be a surgeon. I don't have the fine motor skills, or nor indeed the patients. So why are we different? We have fundamental different ways of approaching things. And I think this is why both of us probably throw bricks at each other. I think undoubtedly surgeons view intensivists as pessimistic, and I think we view surgeons as optimistic, which is helpful when you're working as a team, but when you're both looking after the same patients can be problematic. The focus on what we're providing as an intensivist, where we often only have short-term relationships with these patients, and through the MET team only meet these people in extremis, is that we have a completely different perspective to the surgeon who may have known this patient for a very long time. They may also have been very involved in them through many outpatient procedures, outpatient clinics, prior to them being admitted under a surgical service where there's an operation that occurs. And the nature of the surgeon, of course, is to do physical harm to someone in an effort to make them better. And as an intensivist, we forget this. We don't really understand the surgical mindset that leads to this occurring. So I'm just choosing surgeons as an example because they are the ones I think we least understand as intensivists. And also the conflict possibly around MET teams meeting surgical patients who we believe may be receiving futile treatment versus what the surgeons believe is actually doing well and carrying on may also reflect a variety of things that are outlined here and may go some way towards explaining that mismatch. So what we're talking about really, I guess to some degree, is culture change. If you don't want the MET team to be making these decisions around your patients, then how do we fix the underlying medical culture that is causing this to continue as it currently stands? And there's a variety of things here. There's obviously ethical and emotional challenges about trying to change people's mindsets. One thing I think we forget is that there's prognostic uncertainty. And when there is uncertainty, everything will be done. Over time, you hope that if you continue doing things, the patient's trajectory will tell you whether they were getting better or whether they were getting worse. There is undoubtedly inadequacy in clinician education around talking about dying. And because we work in what I've slightly glibly called a death-denying medical culture, as doctors and nurses, we're fixated on providing acute life-sustaining treatments in the hospital. That means actually considering other things, is this patient actually dying, may actually be quite challenging. So the way we'd approach this in New Zealand, at least at a national level, was to try and rethink resuscitation and to get rid of the process of do or don't resuscitate. It is a form that is largely dead for many reasons, but not least of which is it's a very strange thing that we've chosen to fixate on. Because if you're in hospital and your heart stops, generally that is the end stage of a long process that's led to that point. You have probably had several organs that have failed prior to that point, in which case cardiac CPR is probably much less likely to be successful. The way I describe this to patients and the way our MET team often do is to point out that CPR is actually best working when the heart is the first, not the last thing to stop. So what we've tried to do is to refocus the conversation around what are the goals of care for this admission. We've done something relatively novel, which is to ask patients what they want and to try and provide a medical decision that is focused on what they want to achieve from this, which essentially considers a lot of things, one of which is how much suffering are you prepared to put up with to get you back to a quality of life that you would find acceptable? And that's not simply the same as do you want CPR if your heart stops? It's much more nuanced. It takes more time. And we have a whole process we're working on nationally, including a standardized serious illness conversation guide training and a standardized documented process that we can use to capture the nuances of do or don't resuscitate in a much more gray area. That includes considerations of things that may prolong your suffering, but would only do so if you wish to get to a state that we think is achievable on each admission. So how does this manifest? You may or may not be aware of the rise of a group of people calling themselves end-of-life doulas. Doula is obviously a term that is derived from the Greek as one who serves. But what the process that they'd come to this essentially was, doulas were originally non-trained midwives who were there to represent the mother during the medicalized birth process, where they could advocate for and assist the mother and the father in birth. There's a growing movement over the last 10 years or so where there are now people calling themselves and training themselves as end-of-life doulas to try and provide support for the family possibly in acute care settings where they feel the family can't actually advocate for themselves, and to ensure that the dying process is actually what patients want. So my question really is, has the MET team become an inadvertent doula for death? Why are we good at this? Why should we be doing this? Well, there's a variety of reasons why we shouldn't, which is that we would hope that the home team who know the patient best should be doing this. But this is my pitch, which is the whole point of my talk, about how we should be restoring rest for the soul during the rapid response team. So what do? I think we're quite good at recognizing futility, although not always. We have palliative care regularly round in our intensive care unit, and they occasionally point out things that we think we're doing well that they think are futile. So maybe I'm deluding myself if I think we're good at recognizing it. But what you get if you get a MET call is you get an instant second opinion from someone else who has no emotional attachment to what's going on. They also may be able to make a palliative referral, which the home team may not have thought of. I would say that most intensive care senior trainees have a very good skill set at breaking bad news, whether that's to a patient in extremis or to a family member accompanying them. We are quite good at talking to families and patients in extremis in urgent situations. We certainly have expertise in analgesia and sedation, so providing symptom relief for patients acutely is something we do in the intensive care unit and something we're able to do at the bedside in an acute situation. We know what can be done, and therefore sometimes that leads us to know what shouldn't be done, because we're more informed on the options that can include anything from ECMO to high frequency ventilation and the burden that people have as a result of those things should they survive. By nature, of course, the rapid response team is available 24/7, whereas many of the home teams aren't physically available, and the specialties themselves may obviously have variability during the day even when they are available. Surgeons are operating, people are in clinics. It may be that we're filling this gap, and therefore we can provide some consistency around the things I've talked about before. My point remains, however, that we must train junior staff with these skills if we're going to fill this gap. If we're going to provide rest for the soul, then we must train our juniors. We are legally, morally and ethically obliged to make sure that the skill set we think they should have, we should provide, and we should model this work as well. So finally, this is the standard slide I use. It's the only palliative care joke I know, but it applies in so many situations to make sure that the deaths we provide for our patients are the ones that they want and not the ones that the hospital provides for them by default. We want our patients to die peacefully in their sleep. We don't want them to die surrounded by a MET team sticking needles in them. Some of the onus is on the home team to ensure if they're dying this happens, but some of the onus is also on the rapid response team to ensure, if called to see people, that actually they do the things the patients want them to do. Thank you very much for inviting me and for the opportunity to present once again. I appreciate your time for listening.
All right, thank you, Alex. Thank you for the wisdom of that talk. Less is sometimes indeed better, and rapid response is often caught at the crossroads of this decision making. So let's move on to our third speaker. She is Professor Alison Fox-Robichaud. Professor Alison is a professor of medicine at McMaster University and an intensivist and director of medical education at Hamilton Health Services. She received an honors Bachelor of Science from Biology and Chemistry from the University of New Brunswick and her Master of Science in Medical Sciences at McMaster University. She completed an MD at the University of Ottawa, followed by internal medicine, critical care, and postdoc training at the University of Calgary. She returned to McMaster as faculty in the year 2000, and her research interests include the pathophysiology of sepsis and how evidence is transferred into clinical care. She holds CHRP funding for the development of a point-of-care device for the detection of cell-free DNA, and she's a scientific director of the recently CHIR-funded Canadian Sepsis Research Network. Sepsis Canada is a research collaborative of 190 scientists, knowledge users, and patients and family partners. Professor Alison is the past president of the Canadian Critical Care Society and the inaugural president of the Canadian Sepsis Foundation. She has peer-reviewed more than 95 publications, and which reflects a broad engagement in academic medicine. She's an executive member of the Canadian Critical Care Translational Biology Group and member of the board of the Canadian Critical Care Trials Group and Global Sepsis Alliance. And most notably, in 2015, she received a Leading Practice Award from Accreditation Canada for the integration of an electronic early warning score into the medical record. In 2018, the Global Sepsis Alliance awarded her an individual award for sepsis leadership. And Professor Alison is here to tell us a bit more about using rapid response systems to teach. So over to you, Alison.
Thank you very much, Augustine. And I would say that this topic is going to be less evidence-based because there's not a lot of evidence. So really talking about re-educating residents safely, what I would say is that I'm going to say it's not all about the docs. Re-educating the team safely and how we might integrate physician education into that. Not just for our training doctors, but other members of the healthcare team. So I'm going to take you on a little bit of a journey to think about some of the things that many of us experienced as we were learning to be a health professional, but that also our junior staff experience. So what do we know? We know that the volume of healthcare knowledge required is only increasing. We know that particularly if we think about the pandemic, how much that knowledge has increased in huge amounts over the past 18 months. Importantly, we also know that cognitive overload, and many people may not have heard that term, is common, and it is much more common in learners and junior staff in a hospital setting. And finally, I'm going to give you a little bit of data about the fact that not all training programs actually teach patient safety, something we have been trying to address in Canada, but I wouldn't say it's universal. So if this was the medical textbooks in a century ago, 1922, this textbook, 2-volume, came out in terms of how to manage patient care in a hospital setting. These are only 2 PubMed searches of the volume of information that's occurred around rapid response teams, and if you search medical emergency teams. The huge amount of knowledge that people have to gain as part of becoming a health professional. And with the result of all of that, that cognitive overload is a real issue. Theoretically, we can only really handle in our memory 4 to 5 things at any one time when we're working at the most. And I don't know about you, but at the end of a week of an ICU or whatever I'm doing, my brain hurts. I sometimes call it Fried Brain Friday because we finish our weeks on Friday. There's a bounty of knowledge that we need to be able to do our role. As we continue to learn, that germane knowledge sits in there. There's also an intrinsic load of knowledge that we gather over time. And then there are all the distracting factors that we have, often called an extraneous load of knowledge. And when we have to perform a task under stress, we often go back to some of that knowledge that was easy to put and easy to bring out from our memory, but it is not also always that knowledge that we need to be able to perform a task. And the more junior you are, the more likely you're going to hit that working memory capacity faster. And your capacity to perform the task may actually go down. So this is the concept of cognitive overload. And finally, I think there are gaps in residency education safety. This is from the US group of accreditation graduate medical education, and a review that they produced in 2015. And I'm highlighting a huge overview of certain things that they came out of this report. There's some wonderful, if you look this document up, some wonderful sort of reports of how residents, particularly in this case physicians, did not recognize that it was a particular safety issue in the hospital, nor had they been trained how to deal with that. So first of all, the learning environment and the extent to which our community actually invests in training and integrating patient safety from the level of the faculty all the way up to the hospital administration. So we may talk about patient safety in a hospital, but are we actually training from the time we start medical school, nursing school, whatever school that might be, to think about how we approach safety from a systems point of view? Secondarily, the quality and the engagement that we use into engaging residents, fellows, other trainees in the patient safety that we're performing in an acute care hospital may vary from site to site. And finally, the clinical learning environment itself may not have the resources or the coordination to be able to provide that. We often find that there's a gap between what we teach in school and what we have to do in clinical practice. When rapid response systems started, there was a bit of a back cry, and we've had them in Canada, in the province of Ontario, since 2006. There was this big back cry that maybe we were going to de-skill our physicians and our learners out there in the community, because we were going to have these experts coming, and the residents, whether they were on a medicine service or a surgical service, would not now learn how to resuscitate. So I like this study for one reason, is that they really went out and asked the question. They asked the question of a group of residents, not a bad survey, 236. And what was evident from this was a number of things. Despite the fact that only 50% of the residents who responded to this survey were part of that system or had actually experienced a rapid response team call, they still thought that they were going to not necessarily be comfortable managing a patient without the help of the response team, that they were believed that there were several opportunities for working with the response team, and that importantly, that they had learned enough about the system that they wouldn't be unhappy if the nursing staff actually called beforehand. So at least in this survey, there was a culture of engaging and being part of the response team and learning a valuable educational experience as part of participating with the response team. And for many people, that may be a culture shift that physicians particularly might learn from members of response team, whether it's nursing, respiratory therapist, or physicians on that team. So what is some of the evidence that there may be strategies that actually work to improve the learning associated with a rapid response team call? There is some pediatric literature and a bit of adult literature actually talking about formal debriefing after calls. That may not be possible. Daryl talked about the fact that in their center, you may have 2 to 3 calls frequently in a fully functioning team. You may not have time to go back and debrief after those calls. Pediatric calls may not be quite as frequent, but going back and reflecting, what could I have learned from that call? There is a lot of literature to support that team-based education and simulation is really important in all of this system. And these are exercises, if they are done team-based, will improve the learning of the entire team. And finally, Daryl talked a little bit about this, about policies for escalation of care. We recently introduced this not only to protect the residents so that they were not necessarily getting called for minor issues, but also, importantly, so that they were being engaged early if a patient was deteriorating. They had the opportunity to review that patient, and based on an early warning score, when the patients hit that threshold, then the response team would come. But we have an obligation, at least at our site, that responsible team is also engaged in the care, and they come and they care for the patient at the same time, so there is an opportunity to learn. So what do we need to emphasize for healthcare learners as part of all of this? I think there needs to be primarily a change in culture. It used to be, and we still see this occasionally, that in-hospital cardiac arrests are not necessarily a rite of passage as part of the learning, nor are they a spectator sport. And so cardiac arrests really should be considered a failure to rescue. And this is the principal issue, where as opposed to, I want to come, I want to learn the skill, I want to provide CPR, it's not about necessarily your learning. patient safety really should be a first principle of every healthcare system, and trying to make that system safer. But we need to teach that at the earliest stages of medical school, nursing school, and to other health professionals, so that they're sitting in a culture where safety and harm reduction is part of what they do. So it really boils down to, it's all about collaboration to support patient safety. This is a Canadian document that I think is used internationally around interprofessional collaboration. It's not often seen by the physician community, but it's certainly used by other health professionals. And it can be applied to a rapid response system or to any system within a hospital. It looks at things such as quality improvement, thinking about quality improvement, teaching quality improvement, recognizing that it may be a simple problem or more complex problem, but those problems require fully functioning teams, clarification of whose role is what when that team comes, strategies, providing trainees and learners with strategies to deal with interprofessional conflict and conflict resolution. Alex talked a lot about when the difference between a surgeon and an intensivist, and sometimes when we come to those goals of care discussions, amongst other things, it may be that we're in conflict with the healthcare team. They think we can fix things, others can't. We may be in conflict with patients, but we need to train our learners how to deal with that in an interprofessional manner. Similarly, the context and the issues and how they occur may be very different, and we need to understand that not only we should be having a patient-centered approach, but that we need to work collaboratively, and we need to be willing to learn from experience in other individuals as opposed to somebody who has a particular title behind their name. So the challenge is really, how do we go about doing this? What are the things that we need to think about in a safe culture? How do we work as a team? Recognizing that we need to think about patient safety incidents, teaching our learners how to disclose these appropriately, thinking about and optimizing human system factors, communication tools and giving them tools. Some evidence of, simply teaching residents to communicate is not as important as giving them a simulation-based exercise or an e-learning module. More importantly, training in interprofessional teams has been shown to far strengthen our ability to deal with rapid response systems. So I'm going to finish up with this, but I really want to use this as an opportunity for not only the audience, but my colleagues to think about really how do we approach the learner from the time they start in their health professional training until they cross that border into healthcare. We've seen advantages to this team training. First of all, it often brings junior nurses into the ICU setting, but it also helps, I think, our learners out on the wards to recognize that there is a culture of safety in a hospital. Rapid response teams are part of that culture of safety, and participating in that is an opportunity for learning and enhancing the ability to reduce that cognitive load and gain knowledge from not just the books, but other individuals who see and teach as they care for patients. And with that, I'll hand it back to team.
Right, thank you, Alison. So there's a lot of opportunity for really enhancing our trainee doctors to be part of the rapid response systems. So I'll head straight to my part of the talk. So let's have it on screen. Apologies if I didn't introduce myself for those who are not from Singapore. My name is Augustine T, and I'm an intensivist and respiratory medicine physician, and also chief of medicine at Changi General Hospital in Singapore. And I've been working with medical emergency teams for the last 12 to 13 years. So I will just give a little bit about rapid rescue in Singapore. and some of the evidence we have. So just let me get to the slide. Right, okay. So before I take you to Singapore, maybe you should have a look at what's happening around the world. And I purposely chose the countries around this region, and there really isn't a lot about rapid response in this part of the world. What I can find is some rapid response systems available in Japan. And in this study published last year, it really says that Japanese facilities, hospitals with ICUs, had a very low rate of rapid response teams or MET calls. And only 2 institutions had more than 15 calls per 1,000 admissions. The graph on the right side is a chart of 24 separate individual hospitals and their MET activation rates on the y-axis on the left. And you can see 2 hospitals, the number 1 and number 2, with rates of more than 15 calls per 1,000 admissions. So this is typically what we call the dose response, or the dose of MET activation, which has a direct implication on how it impacts the outcomes with regards to ICU admissions avoided or mortality differences that is meant to make. In Korea, where there's a lot more institutions with rapid response, there was a report in 2019 in the Seoul National University Hospital, where they have a remarkable 62.3 activations per 1,000 admissions in medical wards, and that did show a reduction in hospital mortality. And in other hospitals, for example, the one on the right was in Alison Medical Center in Seoul, Korea, and over a 10-11 year time span, the MET dose, which is the last row on the table, gone up from 6.3 in 2008 to 19.9 in 2018. So it also shows that it takes years for the activation rates to go up to a significant level where you actually make a difference. Interesting, I found one from China, and this was a Joint Commission International Hospital in, I think it's in Hangzhou, China. And really the activation rates were less than 1 activation per 1,000 admissions. And even with that, they've reported some advantages with regards to reduced time for treating patients and some descriptions of success. Over here in Singapore, we've also gone around to survey the different hospitals to look at what the systems they have in terms of recognizing and responding clinical deterioration. And this was a study published last year in the Singapore Medical Journal. And it looks at the response systems in public hospitals. And we chose public hospitals because the private hospitals typically specialists run per patient. Each specialist is in charge of patients. They work less in terms of teams. So we chose the public hospitals. And at that point of the survey, there were 7 public hospitals. Now there's 10. And 5 out of 7 public hospitals responded to the survey. And interestingly, almost all the respondents were a very senior leadership in the hospital who were in charge of patient safety and other policy, as well as institutional structure related to deteriorating patients. And almost all the respondents prioritized the failure to act or recognize deterioration as the number 1 importance among all other patient safety indicators, over and above health-associated infections, falls, medication errors. And there's a wide variety of systems available. Almost all have a written policy and escalation protocol, as well as different kinds of track and trigger systems, and different types of patient observation charts and communication tools. And different forms of different limb response teams. Some have medical emergency teams, some have incorporated into a code blue team, and as well as the mechanisms for administrative and quality improvement, where almost all had regular training and education and a committee to oversee. But there are other differences in terms of collection of specific data. And the most interesting part of the paper was the responses to some of the open-ended questions. And this, I guess, reflects many of what Daryl has shared previously, as well as Alison, about some of the concerns with medical emergency teams or rapid response teams. Specifically to afferent limb, they talked about concerns with regards to sensitivity of the criteria, whether triggering criteria is too generic or is it too specific. They talked about holistic assessment, whether looking at the patient holistically is a better measure of detecting clinical deterioration rather than depending on objective vital signs. And they looked at adherence to trigger protocols, or rather the non-adherence to trigger protocols, concerns about fear of hierarchy when activating response. And in the different limb, there's always this concern that we have insufficient manpower to the anticipated challenges of maintaining such a service, and especially if the service is going to be a 24/7 service. This manpower resource is something that needs to be addressed. And then there are concerns about role clarity between primary and the response teams whenever there's activation episode. Who does what and who's in charge of what and who's responsible for which part of that activation episode. And then there's concern that what Alison had alluded earlier about reliance on the response team for a deteriorating patient. Maybe they would have taken over the learning opportunities of the primary or parent team during activation. And then there's lingering concerns about the administrative and quality improvement mechanisms. Acceptance to change is quite a big issue that the respondents talked about, especially the cultural mindset change required to utilize the system, getting buy-in from doctors. And then there's training, specifically training needed to strengthen the activation and training of many doctors, typically junior doctors who rotate from posting to posting and from hospital to hospital on very frequent basis, sometimes every few months. And then lastly, it's about information technology. Almost all the hospitals have gone into electronic medical records. And then there's a tremendous amount of work to set up this information technology to make it work and to use it to facilitate rapid response detection, as well as the process and the activation episode of a rapid response team. And one of the points that was highlighted was that there are factors that influence when and how clinicians would activate the rapid response systems. And this is another study published by Wei Ling, who's our nursing PhD at the LSD Center for Nursing Studies at the National University of Singapore. And she rightly puts it in a brief summary that RRS activation is a complex intervention that involves navigating through the way clinicians interact with the interplay of social, cultural, political, and organizational considerations. And activations of the RRS were found to be influenced by some of these key factors: frontline clinicians' perceptions of the RRS and their clinical judgment, support from colleagues and hospital leaders, adequacy of the activation criteria, attitudes and responses of RRT members, and adherence to the traditional model of escalation of care, and of course, staff training and education. And so there are many considerations that influence the activation of the RRS. And remember, the more it's activated, the higher the activation dose, and the more likely we will see a benefit in terms of the outcomes of saving patients, which is meant to achieve. Just to show you what's possible, if we have fantastic and talented IT colleagues, and if they put their mind to it, you can have a dashboard that looks something like this. And this is something that we did quite recently in my hospital. It can show you, a whole wealth of data of where activation happens, how it happens, who it happens to, what time of the day it happens, what day of the week, and whether there was a resuscitation or a code blue, or whether what happened before the activation in terms of airway, breathing, circulation. So there is a wealth of data that we can glean out from creating the IT platform to map out where all the gaps may possibly lie and help you design where your interventions is best focused at. So it's not that you've got to build a complicated platform like this, but even a simple platform to help you put your data together actually tells you a lot about where resuscitation happens and where rapid response teams can best be most effective. And just to show you that it is possible if you put your mind to it. This is my own hospital's data from 2008 to 2018. As the orange line shows, and the code blue rates would go down from 2.7 to 1.4 as the medical emergency team activations go up from 1.3 to 18.7 over a 10-year duration. And more importantly, for every 14 MET activation, it reduces one code blue activation. So that again emphasizes the dose response that we need to be aware of whenever such systems are set up. And a lot of it is also about how much internal resources that you need to put on to create that benefit that you want to see. And this is a cost effectiveness analysis that one of my colleagues did for us. And essentially, if we assume that you can have 500 plus activations per year and able to reduce the code blue activations, and the annual cost is the cost of how much you pay the MET team members and how long they spend during activation, and the processes they are involved in during the activation. You have a cost per death averted of 17,603 Singapore dollars, which actually is cheaper than giving statins to prevent death, and also cheaper than running an ECMO service for your ICU. So the most cost-effective measures may be the least sexiest, but it does do the benefit. And the graph on the top left is showing the incremental cost-effectiveness ratio per death averted. So as you see from the cost on the y-axis, the cost will go down as the number of activations per year go up. So as you go from 7 to 800 to 1,000 to 1,200, the cost per death averted actually becomes even cheaper. So that again is the dose response that we're talking about. So it is possible and it is cost effective if the leadership is convinced to run this. And I'd like to end with this sort of summary slide of where we see rapid response or medical emergency teams are in the whole scheme of things. At the bottom of that picture is a cloud. The cloud is the 5 Fs, or what we call the 5 failures in hospital care. And that's the failure to monitor, the failure to recognize deterioration, the failure to respond to the deterioration, failure to escalate, and the failure to rescue appropriately. So those are the 5 failures. And very often the 5 failures are a mismatch between where the patient is at, the care site, versus how sick the patient is, his acuity. So if the sick patient is in the correct site, for example, in an ICU, there wouldn't be this mismatch. You wouldn't need a rapid response team. But if a sick patient is in a general ward, that's a mismatch, and MET activation is waiting to happen. And over above this must be a leadership-driven program, something that Daryl talked about in the beginning. And there are 2 goals. There's a staff goal and there's a patient goal. The patient goal, of course, is detecting deterioration, rescuing from morbidity and unexpected deaths. We don't talk about expected deaths, which is what Alex talked about in terms of rapid response or medical emergency teams at the crossroads of a patient's end of life. And then there's a staff goal, which essentially is a speaking up culture involving teamwork and ownership of the patient, and which is something we are promoting and focusing more in recent years. And above that, there are 4 boxes. There's this ease and willingness of staff to call for help, which I alluded to earlier about the factors influencing the activation of a medical emergency team. And that flows into the criteria, the trigger criteria or the workflow, the afferent arm, which involves systems and processes, whether it be a single parameter or is it a composite score, like an early warning score. And that propagates to an effective response team, whether is it an ICU dedicated team, or is it a nurse-led team, or is it a team made up of primary team or parent team clinicians. It's more important that the response team is effective in the clinical sense as well as in the team. And then lastly, the gray box is to review and improve. And the review improvement is part of the administrative arm that feeds back into the previous 3 boxes. And along the sides, you need to look at quality improvement and research. And on the other end is the communications and publicity internally and externally that you want to maintain throughout these rapid response systems organization. So I end with what Daryl said in the beginning. Rapid response system is a whole of hospital approach. And I will end my talk at this point because I want to leave some time for Q&A. I will get our colleagues to put us back on the main screen. Yeah, so we do have some time for Q&A. And I'm just going to look at the Q&A box. But let me start, while we're looking at it, let me start with a question for Daryl first. You promised to tell us a little bit more about family and carer escalation in rapid response in Australia, where you work.
Yeah, sure. So it's mandatory in all hospital settings in Australia. And it's not dissimilar to the efferent limb approach for clinicians and rapid response systems. So basically all patients and their carers get education when a patient's admitted to the hospital, that this system actually exists. There are posters everywhere about what to do if you're concerned about your clinical status. And so it's the usual process of speaking to your nurse. And if you're unhappy with that response, you can ask to speak to the nurse in charge. And if you're still unhappy, then you can activate, in our hospital, it's called a PACE, P-A-C-E, a patient and carer escalation call. And that gets a response from a nurse consultant, an intensive care nurse consultant in our hospital. But the systems are different in different hospitals. But it's just similar to the MET in that it's mostly a worried criteria. Patients usually don't check their own vital signs unless they've got an Apple Watch or something similar to that. One of my colleagues pointed out that some of the patients in hospital are monitor themselves better than we monitor them, which I thought was quite cute. But yeah, and the people are always concerned that relatives and patients are just going to complain incessantly. But we've found that we have less than 1 or 2 calls every month. So in a whole year, there would be probably less than 20 calls for the whole year. And the vast majority are not complaints about the cleaning and the cooking and you know, my nurse smells or my doctor smells. They're genuine clinical concerns and sometimes they're just a need to improve understanding about things. Not infrequently, it's about something being cancelled, like a procedure or an operation, and someone's very concerned about the timeliness of the care they're receiving. So that would be the commonest, for want of a better word, complaint. But they're usually objective and they're usually not unreasonable. We've found the vast majority of patients and their families and carers are very reasonable. And occasionally there are massive saves. And I obviously can't give you specific clinical details, but not surprisingly, they're around things like sepsis and fluid overload and arrhythmias and cardiogenic shock, those types of problems that junior residents and sometimes nurses might not pick up as readily as even the family pick up, because their dad's just not quite right, or their mum's a bit delirious, or their son's looking a bit clammy. So I think we're very foolish if we ignore the patient and their carers' concerns. So yeah, again, in summary, every hospital has to have one. Most or all hospitals have some sort of a pathway, and they're actually very infrequent, 1 or 2 a month in most studies that have been done.
Right. Thanks. I also want to get to some questions. Question for Alison. How do we get junior doctors to be part of this, the rapid response team, rather than the recipient of it whenever there's activation?
So depends on the model you're looking at. There are a number of models where the junior doctors might be part of the team who goes out if you're on a service. So our critical care trainees specifically rotate through the response team. So they've got a little more experience. They recognize critical illness. They're part of the go out team. But I also think that, they are often the physicians who know the patient best. They've been the ones caring for them. So when the response team comes, and it varies around the world, in our system, it's, they must be there. We are a consultant until such time as we decide that the patient needs to come to the ICU. And so we come as a consultant, we talk to the care team, and we say, what's different about this patient this day? What's going on? Can you help us with this? So it's, the old idea of the code team, when the code team showed up and the rest of the entire care team disappeared, I think is gone. I think we're come as a consultant. What can we fix? Part of the goal is not necessarily to have to bring that patient to the ICU, but to see what you can fix on the unit. So you have to have that communication, and just being there and learning, okay, we do this test. Why are we doing this? What is the approach to this problem? And I think there's learning opportunity not only for junior doctors, but young nurses on the service as well.
Yep. There is a question on the chat. How do you handle debriefing when things don't go right? I guess don't go right during the activation. Anyone? Maybe start with Alex.
That's a good question. I would probably put it another way, which is how often do people actually debrief after MET calls? They're now so frequent that actually having the ability to do so before the next MET call in systems that have it huge numbers is probably quite hard to do. And I know Daryl's talked about this before. Essentially, the main reason being that, of course, there's no one else there observing passively. You're very much in the moment. Undoubtedly, MET calls do go wrong, but we are sending our registrars, our juniors in many cases, out into difficult situations where all the reasons all three of us have talked about, where there may be conflicts, there may be end-of-life care, there may be disagreement within the team, there may be disagreement with the parent team about the right thing to do. All these are areas that are rife for debriefing. And I'd turn it the other way around and say, are we actually causing harm to junior doctors and to ward staff by sending them into this particularly contentious environment with a high mortality group of patients with very little immediate physical support, often verbal support over a telephone? But many centres don't send consultants and seniors out to attend MET calls in the same frequency that they probably should. So how do you handle debriefing? I would take it back a step and say that we should probably have a debrief, never mind how do you handle it. Even having one would probably be a good start. And having senior presence more frequently with the properly funded MET service would be the way to go about that. But many of us don't have that because they've been built up ad hoc without prior funding.
I can speak to that, Augustine. I think following on from what Alex said, I think that having end-of-life care MET calls causes particular moral distress amongst junior trainees. Up to 1 in 5 MET calls with end-of-life care cause distress. That's the first thing. We don't debrief every MET call at our organisation, but what we do is go back with salient or standout ones and either commend the team for a massive save or to go back and feed back to the team if it's been traumatic. And they tend to be hot debriefs where we just check on welfare and provide immediate feedback. Sometimes the formal debrief happens at a ward level and our role is just to notify the people on the ward, like the senior nurses. And that's the second thing. And the third thing, again, following on what Alex was saying, we now have a consultant on our team, and the major thing that the juniors perceive is the moral support and the oversight that they get, in addition to the senior clinical expertise. We would never let a junior doctor run an ICU ward round on their own without senior supervision, and yet we allow them to go out on a rapid response team where it's totally chaotic and unpredictable and do exactly that. It has to change.
I think it's one of the reasons. Yeah, I think it's one of those reasons as we built the system, at least in Ontario and Canada, that it was physician part of the team from the beginning. So a staff intensivist from the beginning, because partly authority, partly the ability to teach and provide, and a learning opportunity. Many physicians, particularly even not necessarily experienced in learning from a senior nurse, for example, they don't feel comfortable learning from a nurse. And so the culture change that we've experienced over 15 plus years is now they're used to seeing those senior response team members out on the ward. They're used to learning from nurses. And that's probably that biggest interprofessional collaboration is, who are you learning from? You know, it's not until those junior house officers come into an ICU and realize the smartest people helping them in the middle of the night are those same experienced nurses, then they really understand that, you know, the ICU nurses are their friend, whether they're in the unit or out on the unit on the wards.
Agree.
Me too.
Okay, I don't think we have time for another question, because we run out of time. Although we can talk on for a lot longer. It only leaves me to thank Alison, Daryl, and Alex for a fantastic session today, and I hope our audience have some points they can take home with. And we do ask everyone to stay safe during this period and enjoy the rest of the conference. So thank you, everyone, and take care.
I'll say good night from Canada.
Good night.
Thank you, everyone.